Good afternoon, everyone. It's an honor to be invited to talk on a very important topic, which was not been a focus in our day-to-day practice till long, and now we have realized that we need to be also looking at the aspects of nutritional care. And this topic being given has made me more enlightened how to look at the nutritional issues in the context of critical care nephrology. So my topic is nutritional evaluation of critically ill patients who have reduced renal function. It is very important to realize that the reported statistics of malnutrition in a hospital setting is very serious, that every third patient in a hospital or an ICU has some degree of malnutrition. Awareness among health professionals like me and many of us is quite poor, because most of us ignore this parameter in our treatment because of inadequate training in the past. There is a huge gap between our knowledge and the real practice of the ideas for nutritional care. We have less focus on dietary intervention and more on the medical interventions in patient care. Nutritional care in our day-to-day practice suffers from the lack of division of responsibilities between doctors, nurses, dietitians, who are not working often as a team in this context, and hence this forum is probably the right forum to at least bring awareness among the interactions between the different specialists who take care of such issues. It has been reported that patients in ICU are at very high risk of nutritional deficiencies. Every critically ill patient who stays in the ICU for more than 48 hours is considered to be at risk of malnutrition. It is said that patients who come to ICU in the beginning are having 1/3 of them are having some form of malnutrition, and if they are not focused so far nutrition is concerned, the remaining at least 1/3 of patient again develops this protein energy wasting by the time they leave ICU. That is, this problem is quite common in an ICU setting, and it has to be focused. Medical nutrition therapy there should be considered for all patients who are in the ICU, mainly for more than 48 hours. So as a clinician, when we look at the malnutrition in a patient who is in the ICU or in outside the ICU, we try to look at the patient as a type 1 malnutrition or type 2 malnutrition if they have any form of malnutrition. Type 1 malnutrition can be considered to be a kind of malnutrition where there is no inflammation or very mild inflammation, with malnutrition basically associated with starvation kind of situation, that is person eating less. While the type 2 malnutrition is a situation where patient has a lot of inflammation and comorbidities, which is difficult to treat, and it is the thing which is associated with high risk of mortalities if not properly addressed. So this is maybe a clinical setting to look at when we look at a patient for nutritional care. We look at it whether he has or she has a type 1 or type 2 malnutrition in a simple way. So when we look at the nutritional assessment, the aim of this assessment is to identify at-risk patient or malnourished patient so that we can reduce the complications which are associated with malnutrition, like increased incidence of sepsis, bed sore, the increased incidence of treatment failure, that is failure to wean the patient out of the ventilator early, poor wound healing, mortality related to arrhythmia, bleeding, and many multiple factors which contribute to mortality, increasing length of hospital stay because patients remain in the ICU because of hospital as well, because of ventilator requirement, and because of this, the healthcare costs. And that is the reason we need to focus on the nutritional assessment. So the goal of nutritional assessment as well as management is to prevent the basically protein energy wasting in ICU setting, to avoid complications and reduce or prevent mortality by improving wound healing in the surgical setting, improve the immune functions by appropriate diet, minimize inflammation by appropriate interventions, improve the antioxidant activity, the diet that are available, and based on these kind of considerations, we can improve in the endothelial function and increase cardiovascular mortality. And that is the basic goal of our nutritional assessment. So in this context, when you talk about nutritional care, it is a two-step process. The first step of nutritional care process is to do a screening, which is a nutritional screening, which is just like a Q-SOFA or quick SOFA that we commonly employ to assess whether a person requires hospitalization or ICU admission. So nutritional screening is the first line process to rapidly and accurately identify patients who require a more comprehensive nutritional assessment, if that is so. And the tools for nutritional screening are listed in the slide. The commonest tool that is employed by all our dietitians in our hospital is nutritional risk scoring, the NRS scoring 2002. Though another kind of score is also possible to be employed, that is the malnutrition universal screening tool or MUST tool. 3 or 4 tools are mentioned just to complete that. The tools which are available in the literature, like nutritional risk index, geriatric nutritional risk index, many nutritional assessments short form, and malnutrition screening tool. There are many other tools which are there, but for all practical purposes, when we are trying to screen a patient, the NRS 2002 is the commonest nutritional tool which is employed, followed by the MUST tool that we are going to discuss in the subsequent slide. So that was the first step of nutritional assessment, that is, we try to nutritionally screen and decide which patient requires a detailed assessment by the nutritional assessment chart. The nutritional assessment detail is the second step of nutritional care, where we try to identify and quantify the specific nutritional problem. And the tools which have been developed to look at this nutritional assessment in detail are listed in the slide. That is subjective global assessment. Basically, it is utilized for hospitalized patients, and this is also utilized in the ICU care setting and is recommended by the Indian Indian Organization of the Critical Care, that this is the tool which can be employed in our day-to-day practice. There are other kinds of tools like patient-generated subjective global assessment and mini nutritional assessment for the elderly, but is hardly used. The other tools which are mentioned in the literature, other than this subjective global assessment, is the NUTRIC tool for the ICU patients. And in a dialysis setting, dialysis malnutrition scoring as well as malnutrition inflammation scoring has been also discussed, but they are all the research tools and which are not practically used. So coming to the important first screening tool that we talked about, the nutritional risk scoring 2002, which is employed in our hospital by our dietitian and maybe getting used in many other settings, is a simple tool to use, where we look at 2 parameters. One is the nutritional status, and other is the severity of disease which required hospitalization. And each parameter is given a score of 0, 1, 2, and 3. Like 0 is there is no nutritional abnormality. Mild one is the weight loss of less than 5%, or a BMI in the right range. Moderate or the score 2 is when we find that patient has a weight loss of more than 5 to 10% in 2 months time, or a BMI between 25 to 18. And score 3 is the other extreme. Similarly, the severity of the disease is scored as 1, 2, and 3. For example, a patient of renal failure with chronic hemodialysis patient getting hospitalized will have a score of severity of disease of at least 1. And if he's on ventilator and other things, his severity score will become 3. So this is how we try to look at it very cursorily to decide which kind of nutritional risk that patient is having. And any person who has more than 70 years, one more point is added. And based on this addition of these points for nutritional status, severity of disease, and age, person is categorized as a high risk or a low risk. Any person who has a scoring of 0 to 2 has to have a kind of assessment every week because he's a low risk patient. But any person in the risk category of 3 to 7 needs to have a detailed assessment, that is basically the subjective global assessment. The other tool which can be used as a screening tool is shown in the slide, that is the MUST tool, which is a simple tool which can be also employed even in the OPD setting. That is step 1 and 2 and 3, where we look at the BMI, look at the weight loss in last 3 to 6 months, and look at his eating habits, that is either he is able to eat or not for last 5 days or more. And based on the points 1, 2, and 3, we try to add up to make a risk calculation. That is, a low risk patient is one who has all the parameters in the good range. Medium risk is a person who has at least 1 point in all these 3 kind of steps. Or 2 is the situation where the person has more than 1 parameter abnormal. And persons are graded as low risk, which requires a routine clinical care. A medium risk, where person has to be observed more closely. And the high risk, where person has to involve a dietitian to look at how to take care of his dietary risk. And this is also a kind of tool which is not only utilized in the ICU setting, but it can be utilized in the OPD setting, as even the nursing hospital in a small care settings. So that was about the screening tool. But when you try to look at the screening tool and decide to go for a next step of assessment, that is a person who is at high risk, these are the tools which are utilized for detailed nutritional assessment. The first concept of nutritional assessment is anthropometry and body composition. The commonest kind of parameter which is utilized for anthropometry is height, weight, and the body mass index. Other things in the anthropometry like skin fold thickness and mid-arm circumference is also utilized in certain settings, particularly research setting and when you're doing a thesis work. DEXA, that is BIA, that is our total body nitrogen, ultrasound and CT are reported as a kind of tool to be utilized for body composition, but it is not a common tool that is used in day-to-day practice. Biochemical parameter is another kind of tool which is utilized for nutritional assessment, and the lab values, particularly of albumin or a pre-albumin, is utilized to decide which way the person has to be scored. In the clinical category of nutritional assessment, we look at the symptoms of particularly food intake, the appetite, and the signs which could suggest the person has a kind of malnutrition, and the clinical stress points to decide which way to assess the symptomatology. We try to look at the dietary intake by the interview, recall, and many times if the person is stable in a chronic setting, we can collect the 24 hours urine to assess the urine and nitrogen appearance, because that gives an idea about the protein intake. And all these parameters are ultimately included in the SGA tool, that is the subjective global assessment tool, to come to a conclusion. And the urinary nitrogen appearance that we spoke is occasionally utilized to categorize the patient as a catabolic state, or trying to look at what is the amount of protein the person is taking. The complex or advanced methods of nutritional assessment is occasionally used in research settings, where we try to look at the body composition, like the neutron activation the tool, or DEXA scan, or the NMR spectroscopy, or bioimpedance the anthropometry, which is being utilized in certain advanced center to look at the body composition. So coming to the most common tool that is employed in all the settings where nutritional assessment is done is the subjective global assessment, which employs at least 5 parameters in the history, that is the weight change in the dietary intake, change in the GI symptomatology, the functional capacity of the patient, the link between disease and nutritional requirement, which is basically stress factor, and looking at the physical examination, which are focused to nutritional deficiency, and patients are given a label of category A, B, or C. A means person is having a kind of is well nourished, or SGA A category is well nourished patient, SGA B category is moderately malnourished patient, and SGA C category is a severely malnourished patient. So A, B, and C are the usual abbreviations which are utilized, but occasionally these categories can be scored based on the score from that is from 1 to 10. We can put the scoring in all the categories, and a person who has 6 to 7 points in each category is category A, 3 to 5 points is category B, or 1 to 2 points is category C. And that is how either you can go a subjective way to look at A, B, and C, or slightly more objective ways to score the patient and categorize the patient as SGA A, B, and C. So all these factors are revolving around few common things that we commonly look at in our day-to-day practice. So what is the weight of the patient? Because it's very difficult to remember so many formulas which are already there in the textbook or may be utilized. But I found that Broca's formula, which is there in our textbook of preventive and social medicine, quite handy, that we don't have to remember anything. Height in centimeter minus 100 is the expected or kind of weight for the patient if he's male, and 0.85% of that calculated figure should be for female. And that is the weight that we look at in all our patients to decide whether a person is underweight, overweight, or needs to be focused on that. There's a term called adjusted body weight. When we utilize this adjusted body weight, when we find that body weight is extreme, either too high or too low, particularly in dialysis patient, and then there we try to calculate the adjusted body weight by a kind of formula which is ideal body weight into 0.25 and observed minus ideal. So that was about the concept of weight that we normally utilize in our day-to-day practice. Then we try to look at the weight and height ratio, which is the commonest kind of anthropometry data for our analysis. And we analyze the person as mild nutrition, malnutrition, moderate malnutrition, and severe malnutrition based on the BMI, which is below 18.5. And any BMI above 23 is considered to be overweight, and more than 25 is obese. Underweight and overweight both are considered as a malnutrition. The third thing that we can employ in a situation where we are not able to measure the height and weight in a patient, we can look at the mid-arm circumference, which is easy to measure, and it is said that any person who is a male and has a kind of mid upper arm circumference is less than 23 is malnourished, and that will be corroborated by the BMI and other parameters. And female below 22 is a kind of centimeter, is a kind of factor which is considered as malnutrition. So when we look at the weight, we try to calculate the weight based on the chronic weight loss or acute weight loss. The chronic weight loss is a weight loss over 6 months, while acute weight loss is the weight loss over 2 months or 2 weeks. And this is 5, 10, and more than 10 is the category of scale for mild, moderate, and severe kind of weight loss. So, but we need to understand that when I'm looking at this anthropometric data and the biochemical data, these markers have this limitation, particularly in kidney disease patients, like the albumin, pre-albumin cholesterol may be altered by inflammation. Similarly, the body weight can get altered because of the fluid overload. Anthropometric data like the muscle mass, etc., could be difficult to analyze in a person who is fluid overloaded. Energy expenditure formulas, which we will discuss in the subsequent slide, may not be valid in a very catabolic setting. SGA score, that is the subjective global assessment data, has not been fully validated in AKI, but it is the common kind of tool that is employed. And the body mass composition that we talked about by looking at the bioimpedance analysis, CT, MRI, etc., are not been validated or not available. And hence, these kind of parameters are basically to give a talk, but not is easily employable. So in a ICU setting, we try to look at a patient from the nutrition standpoint into a moderate to severe malnutrition based on the phenotypic criteria that we talked about, the weight, body mass, and the muscle mass, and the other criteria of etiology based on his food intake and the disease inflammation. And then we categorize the patient as SGA A, B, or C. So in the context of acute kidney disease or chronic kidney disease in an ICU setting, if you find that one of the parameters in the biochemistry like albumin is below 3.8, or one of the parameters of anthropometry in the form of weight loss or body mass index is below the target range, below 23 BMI, or a person has a poor dietary intake in the form of less than 80% of the dietary protein intake or calorie intake, he or she is having a malnutrition. There is another kind of tool which is being talked about in the ICU setting in the research kind of this report, that Nutric scoring is basically a better tool in critically ill patient, which encompasses various variables like age, Apache score, SOFA, number of comorbidities, number of days in ICU, or interleukin 6. And based on this scoring, person can be categorized to have either a high score or low score. If IL-6 is available, we add. If IL-6 is not available, that is interleukin 6, we have a different kind of scoring. But this kind of scoring are not used in our ICU practice because many of the parameters are not checked. Many of the parameters are dependent on the doctors, and maybe the nutritionist may not have a kind of availability of those information. And hence, they employ still the SGA scoring in the ICU setting. So we categorize the patient as catabolic or non-catabolic from the clinical standpoint. A person who has infection, acidosis, or multi-organ failure is having a catabolic kind of ARF and will require more kind of care compared to non-catabolic patients like post-renal AKI or pre-renal AKI, which can be managed with the enteral nutrition. So we classify the patient as catabolic or non-catabolic based on the urea nitrogen appearance, and urea nitrogen appearance can be multiplied by 6.25 to get a protein that person is consuming, and NPCR is another way to look at the parameter. So patients with AKI are considered as mild, moderate, or severe renal failure and categorized into 5 to 10, and more than 10 based on the UNA appearance, and we try to give a different kind of calorie intake as well as this amino acid intake and glucose. So when we look at calorie, we try to go by a simple calorie calculation of 25 into weight, but there are many kinds of gadgets which are available which can easily calculate how much is the calorie required for such patient. So nutritional requirement per ARF is shown in the slide, that we at least have to focus on 30 kilocalorie of energies with appropriate carbohydrate and fat, and give at least minimum of 0.6 to 8 gram of this protein. But in a patient who is on extracorporeal therapy requires higher protein. In contrast to the protein restriction and calorie restriction in patient on dialysis, we need to at least look at our patient who are in pre-dialysis phase, who are chronic. We give higher calories between 30 to 35 with the protein as is recommended by the various guidelines in the range of 0.6 to 8 in the pre-dialysis phase and 1.2 to 1.5 in the dialysis phase. So to conclude, when we are looking at the patients for analysis of nutritional parameters, we need to identify the patient who has risk by screening tools that we talked about, the NHS 2002 or a MUST tool. We need to assess the patient in detail if you find that person is at higher risk by a kind of subjective global assessment tool, or if possible, the Nutric tool in the ICU setting. We need to categorize the patient as a catabolic patient or a non-catabolic patient based on clinical profile and UNA. Give a nutritional diagnosis based on the patient as this SGA, ABC, AKI, and HRS. Suggest target and follow up periodically with oral, enteral, partial, parenteral nutrition or total parenteral nutrition with optimal energy and other components. Thank you.